In this capture, we're going to move on down and start talking about some intestinal disorders. Hitting some key points of appendicitis, very classic, umbilical epigastric pain that then moves to the right lower quadrant. And classic also is rebound tenderness. What that means is your patient actually feels more pain when you push on the abdomen, when you let go versus when you push on it. So it hurts more, it's more tender with the rebound. Nausea and vomiting is also typical for appendicitis, as well as a fever. Typically, this is going to be diagnosed with a CT scan. Blood work is going to show an elevated white count and neutrophils, and it's treated with surgery. Preoperatively, obviously the patient's going to be NPO. We're going to be pushing IV fluids in them, again, to support that circulating volume. They'll typically use IV antibiotics, at least a dose with the cut of the surgery. If the appendix has perforated, they may follow up with some additional doses of IV antibiotics. We'll use antiemetics to help manage the nausea, and we'll use semi-Fowler positioning with the right hip flexion, and that helps take some of the stress and pressure off of that appendix area. Postoperatively, a lot of your appendectomies are done laparoscopically, or they're done through a very small open incision. We're talking, maybe 4 inches at the most, sometimes even smaller than that. Postoperatively, again, pain management is going to be important. Typically, we'll use the non-opioids first, the acetaminophen, the ibuprofen, around the clock, and then, potentially something stronger for breakthrough pain, perhaps something like Ultram. Initially, starting with clear liquids and advancing the diet as tolerated. Again, if an actual perforation occurred, they'll have additional doses of IV antibiotics. The surgery will take a little bit longer because they'll do a lot of irrigation to really kind of clean things out. Not as much anymore, but years ago we used to see maybe some NG tube with lavage and surgical drains with an appendix that's ruptured. It really depends on how well the surgeon is able to really clean out the area, how big the perforation was, and how well they're able to clean out the area internally while they're in there doing the surgery. Peritonitis refers to inflammation and infection of the actual peritoneal cavity. So perforation, kind of bowel perforation, whether it's the appendix, whether it is the stomach perforation, the small intestine from an ulcer, basically the organ opens, all the contents that were inside spill out into the peritoneal cavity. The peritoneal cavity is supposed to be sterile. Inside the bowel, you have a lot of bacteria, digestive enzymes, things like that. So you can see when it perforates, it causes a major problem. Very severe abdominal pain, very severe. And they'll be uncomfortable beforehand, but at the actual moment of rupture, when it kind of bursts open, the patient will actually feel a slight pain relief because the pressure that was building inside there is now actually relieved. However, that is very short-lived, and that pain comes back, and it comes back with a vengeance. The abdomen also becomes very stiff, very firm and rigid, and the fever is going to spike really high. If we're looking at lab work, the white count is going to spike. We're talking over 20,000. And the CT scan would obviously show the perforation, and it would show the contents in the actual peritoneal cavity. Now, something to consider when we talk about a perforation, sometimes it's a very small perforation. And the body, in some cases, can actually self-seal that perforation. It really depends on the size and the location. Most of the time, if we're talking a perforation, we're going to require surgery. It's going to be peritoneal lavage, where they are constantly irrigating that peritoneal cavity to really, really kind of clean it out. And then several doses of antibiotic therapy after the fact to kind of cover the risk for infection. Our next topic, and really our main topic for the intestinal disorders, is going to be colorectal cancer. Just a note here, we are going to have a more extensive cancer unit as part of Unit 6. So what I'm going to do right here is more focusing specifically on colorectal cancer. We'll get into the specifics with chemotherapy, radiation, that sort of thing in the actual cancer unit with Unit 6. But with colorectal cancer, most of them are going to start, or well, they're going to be adenocarcinomas, and most of them have started as a polyp. Okay? If it's left untreated, it's going to continue to grow. As the size of the polyp increases, the cells begin to invade other tissues, other structures, and it can metastasize to the liver, lungs, brain, or bones. Those are usually the typical spots of metastasis for colorectal cancer. So thinking about health promotion and disease prevention, colonoscopy, screening colonoscopies are critical. Typically, this should begin at age 50, and depending on what the results are, patients generally recommended to follow up every 5 to 10 years. If they find something abnormal, they find a bunch of polyps, they take some things out, or if there's a strong family history, they may require more frequent scopes. Years ago, I took care of a patient down at Jersey Shore who had a family genetic issue with colorectal cancer, and this person actually had colonoscopy screenings every 6 months. And every single time they came in, they were always finding more and more that they were taking out. But had any more time elapsed, they would have probably had a very significant colorectal cancer. So colonoscopy is critical. The other thing that's recommended is a yearly DRE, a digital rectal exam, with occult blood testing. So essentially, with the digital rectal exam, they're looking to see, can they palpate any tumors in the lower part, in the rectum, sigmoid, colon. They're also getting a sample of stool on the glove that they can then test for occult blood. And occult means hidden, so microscopic blood, because that's one of the things that you will see with colorectal cancer is there will tend to be microscopic bleeding. And again, because it's microscopic, the patient doesn't necessarily recognize that it's there. Other things that we can look at to try to promote health and reduce the risk for colorectal cancer is consuming a diet high in fruits, vegetables, and whole grains. The idea with the fruits and vegetables and the whole grains, it adds fiber, it increases bulk to the stool, which then stimulates peristalsis and evacuates things from the bowels more quickly. The whole theory behind that is the longer those chemicals and digestive enzymes are in contact with the intestinal tissue, the higher the risk of developing cancer. So we want to get things moved through. We also know that high-fat diets and red meats, your animal meat proteins, tend to be associated with a higher risk of colorectal cancer. Alcohol should be drunk in moderation, really focusing on smoking cessation. Those two things are also tied to the development of colorectal cancer. So in your patients with clinical manifestations, this is why screening with colonoscopies is so important. Because the early symptoms of colorectal cancer are very vague, very nonspecific. So many people, if they're not getting screened, by the time they're actually having true symptoms, the tumor has gotten large enough that we're starting to see some abdominal discomfort, some obstruction symptoms, and by that point, it likely has at least invaded regional tissues, if not evolved to distant metastasis. So, clinical manifestations, blood in the stool. Again, we talk about occult hidden blood. The other thing that you might see is the black tarry stools, or you may see actual bright red bleeding or maroon bleeding. The other big thing, and we tell patients to really be on the watch out for this because they know their body best, is a change in bowel habits, especially if there's not something that we can attribute it to. Now, for example, if you're out working, you're not drinking as much, you're dehydrated, and you get constipated, that makes sense. There's a reason for that. But if nothing has changed, you're not on new medications, your dietary intake, your fluid intake hasn't changed, and now all of a sudden you're noticing a change in bowel habits, perhaps constipation, diarrhea, that's a red flag. It doesn't necessarily mean for sure that this person has colorectal cancer, but it's enough of a red flag that they require additional workup to figure out what's going on. Abdominal pain and rectal pain are associated with colorectal cancer, other things as well. So, again, it's a thing that they need to get checked out. Cramping, gas, sometimes an actual palpable mass. Other things that we'll typically see is weight loss and fatigue. And we'll talk a little bit more about that in the actual cancer unit. But the weight loss is going to be related to the fact that cancer cells use more energy. Okay, so the calories that the patient is taking in are actually going to feed the cancer cells, the cancer cell energy. And because of that, because of the microscopic bleeding, the blood in the stool, you'll have low H&H, they'll be anemic. The patient's going to be very fatigued, very tired. As the tumor progresses and gets larger, you may see abdominal distension, abnormal bowel sounds where it actually becomes absent bowel sounds below the level of the tumor, feeling of incomplete evacuation, that's something still sitting there, also vomiting as it becomes the obstruction and things get distended. Again, the best thing for this is really the screening colonoscopies. We want to catch it early. We want to catch it before they're even having symptoms. Early identification, early diagnosis, early treatment is going to typically lend itself to a better outcome. So diagnostic studies, I mentioned some of these a little bit. The fecal occult blood test will show positive for hidden blood. CEA is an enzyme. It's a serum test, a blood test, but it's looking at an enzyme that's typically associated with cancer. So they'll watch that to see if it's elevated. They may also draw them periodically in somebody that has a known cancer because it's kind of indicative to see how they're responding to the treatment. And I mentioned before, this patient's going to be anemic. Their H&H is going to be decreased due to that intermittent bleeding in the bowel. Diagnostic procedures, we mentioned the colonoscopy. This is going to provide direct visualization. If polyps are identified and found in there, they can possibly be removed. We can take tissue samples for biopsy. Another test that you may see would be the barium enema. And this is very similar to, we talked about the barium swallow where they drank the barium contrast. In this case, the barium contrast would be administered via enema, and they'd be taking pictures. Again, the barium acts as a contrast, so it can show anatomical abnormalities such as tumors, that sort of thing. And of course, CAT scans are going to be able to visualize the presence of a tumor or an obstruction. Chest x-rays and liver scans are helpful if we're looking towards metastasis. Again, treatment is going to depend on the stage of the disease, but generally surgery is going to be the first line treatment. So with surgical resection, the whole goal is to completely remove the tumor and a margin of healthy tissue. Okay, we want to get clean margins, and in a perfect world, we get clean margins and then we can reattach the remaining tissue. Sometimes that can't always happen. Sometimes it can happen, but just not right away. So these procedures may require an ostomy. And that ostomy may be permanent or it could be temporary. So when you're taking care of a patient and they have an ostomy, you kind of want to know why. And you kind of want to know, is this a permanent, is this a temporary thing? And you'll see on the screen the two types of ostomies we kind of think about from the bowel. We have a colostomy, where the stoma is brought out and it's from the large intestine, or an ileostomy, where the stoma is actually a portion of the small intestine, the ileum, that's brought out onto the abdomen. And you'll notice, we talked about in a previous capture, the primary function of the small intestine was absorption of nutrients. For the large intestine, it's going to be absorption of water, absorption of fluid. So your patient, if their if their bowel contents are not going through a decent portion of the large intestine, their stool is going to be liquid. They're going to lose a lot of that liquid, and they're at high risk for fluid volume deficit. You can see on the screen, the farther your contents move through the large intestine, the more water that gets reabsorbed, and that's going to change the consistency of the stool. With colorectal cancer, this picture just kind of depicts where ostomies could be, what the different areas are anatomically. And this is pretty important because you want to know what area of the colon is diseased. We're talking about colon resection in relation to cancer, but these same principles are going to apply to things like inflammatory bowel disease, Crohn's disease, in some cases severe diverticulitis where there's hemorrhage, where they might need to do a partial bowel resection. So that's going to apply the same situation with the surgery and potential ostomy. So with preoperative care, we're really focusing on emotional and psychological preparation. In a perfect world, somebody who's having a bowel resection related to cancer, this would be a planned surgery, a scheduled surgery. They know they're coming in. That doesn't always happen. There are some cases where the patient comes in with the abdominal pelvic pain. As part of the workup, we identify that they have colorectal cancer, there's a tumor there, and that tumor is fully obstructing. So they have to go in and treat it surgically. In a perfect world, we want that scheduled surgery because there's a lot of emotional and psychological preparation that really needs to go into this. Not only the C diagnosis, the cancer diagnosis, but the reality of the fact that they may have an ostomy. Or, to be crude, they might be pooping in a bag. That is really something that is emotionally terrifying to a lot of people. So that emotional, psychological preparation, if we're able to do it, is a critical piece. You want to acknowledge their feelings, encourage them to continue to verbalize, look at their support system and their coping strategies, and kind of, be able to empathize with them and suggest positive coping strategies. Something that's really critical, though, is to really get them linked up with a support group or a support person. If somebody can visit them who has an ostomy or who has had an ostomy, that is huge. Because the reality is, I don't have an ostomy. I've never had one. I don't really know what it feels like to have one of those. So sometimes talking to someone who has, walked in their shoes, that they can ask questions like, well, how do you take a shower? Or did people know that you were wearing the bag underneath the clothing? Or how did your partner react the first time they saw you with the stoma in a bag, undressed? Those are all things that they're going to be dealing with. So having them connect with a support person can be a great strategy to help with that. We also want to use the wound ostomy continence nurse. These are registered nurses with additional training in wound care, ostomy, and continence. They go for additional education, additional training, and they actually take a certification exam. They can be very helpful as part of the interdisciplinary team. From marking the ostomy site where the doc plans where it's going to be, to selecting ostomy appliances that are going to work best with the patient's body. How do their skin folds go? Is it concave? Is it convex? And what's going to work best? Preoperatively, they are on a bowel cleansing regimen. Again, they want to kind of clean everything out of the bowel. They also want to reduce the amount of intestinal flora as much as possible. So typically they'll be on some pre-op oral antibiotics as well. Post-operatively, they're pretty much just like any other post-operative patient, with the exception that you have a couple of things that you need to specifically look at. In relation to the stoma, you need to look at it. Normal stomas are going to appear moist. They're going to be like a beefy red. It looks like raw meat, okay? They're literally taking intestinal tissue and bringing it out as a stoma onto the abdomen. It is expected to have a small amount of bleeding because that intestinal tissue is very highly vascular. Okay, think about it. Whether we're talking an ileostomy or a colostomy, both of those, their main function is to absorb. The ileus was to absorb nutrients, the large bowel was to absorb liquid, but they absorb. They're very vascular. So you want to be very careful. You don't want to bang the stoma at all. You don't want to bump it because that can cause an increase in bleeding. Okay, but you have to look at that stoma. If it's looking pale or it's starting to look blue, there's ischemia. Okay, that is a call to the provider. The patient will likely need to go back to surgery. Hopefully, we get it before it becomes black and necrotic. Okay, because now you actually have tissue death. It's important to remember that the stoma is going to be fairly large at first. Okay, there will be some swelling. That size will begin to reduce. It will shrink over the coming weeks as the patient heals and that inflammatory process subsides. Okay. Other than that, these patients are very much like any other surgical patient. Okay, you're still getting them out of bed, you're still getting them up and walking, you're still doing coughing, deep breathing, incentive spirometry, splinting the abdomen, still worried about atelectasis pneumonia, still looking at DVT prevention. None of that has changed. The other added piece is going to be teaching them how to care for the ostomy. Okay, how to clean the stoma, how to clean the surrounding skin, and how to actually apply the ostomy device itself. We want to consider altered body image. I don't care how strong your patient is. If it's a planned surgery, they can come in, they might be able to state to you, okay, I'm going to have surgery today, they're going to take out part of my bowel, and when I wake up, I'm going to have an ostomy. They might be able to verbalize that all well and good. But when they first wake up in PACU and they've had that first moment where they look down at their abdomen and they see that stoma, that's when it hits. They go through a grieving process the same way someone does if they lose a person with death. Okay? But they will go through a grieving process. So again, therapeutic communication, you want to acknowledge their feelings, validate their feelings, encourage them to question, encourage them to verbalize. You want to encourage the patient to look at the ostomy and begin participating in the care. And again, as I mentioned before, you want to facilitate contact with other people who have walked in their shoes, who have been there. That kind of leads into some sexual dysfunction. We could be talking a physical issue in relation to the cancer itself, the surgery itself, nerves that were cut, the inflammatory process. It can also be psychological, as I mentioned before. What is my partner going to think when they see me undressed and I have a stoma in a bag? Okay, so again, helping them verbalize their feelings, getting them linked up with a support person. And in some cases, when this becomes, a bigger issue that those other techniques aren't resolving it, it's something that they might need counseling, both for themselves and for their partner as well. Postoperatively adapting to an ostomy, they're going to advance their activity as tolerated. Typically, their full activity in about 6 to 8 weeks. They really should not be doing heavy lifting, just simply because it can cause additional bleeding until healing happens. Bathing and swimming are okay. I wouldn't say swim right away, but as they heal, they can go back to taking baths. They can go back to taking, swimming in pools. They should avoid direct sports, just simply because of the potential trauma on the stoma can cause bleeding. Sexual activity is as tolerated. Thinking about being ready for discharge when talking about ostomy care, again, we want to encourage the patient to participate in that as they're learning. Who's ever going to be doing it, we want to teach them, have them return demonstrate that. Particularly for ileostomies, we want the patient to be able to verbalize strategies to prevent dehydration because of the fluid that they lose there. And also strategies to prevent nutritional deficits or deficiencies. And again, really focusing on that support system and community resources.